Ja, har ni haft det gott med lunch? Ni känner er mätta och förhoppningsvis inte trötta, för vi ska få lyssna på, we're going to be listening to Florence now, and as she told me earlier, it's very dangerous to have the talk right after lunch, you know, so you have to be really kind of on the ball. I would like to welcome Dr. Florence Schmitt from Finland. She's an individual psychotherapist who works with families where a parent is dying. She has written this book, which you can still get copies of out there. It's given out by Respekt. Liv lämnar dörren öppen, guide för patienter som flyttats till palliativ vård samt för patientens anhöriga. Mycket fin liten skrift. Så jag lämnar över nu till dig. Varsågod. Ja, du ska ta den, ja.
Tack. So, yes, I thought it's very dangerous to have a speech just after lunch. How many of you are nurses? Because nurses are not used to eat. and then when they have the chance to have a good food, they are falling asleep. And don't be worried about that. If the eyes are getting closed, it's not a big problem for me. Additionally, if you keep the eyes open, they will make some wrinkles on your forehead. So, but before we are starting, I would like to introduce my colleague, Leo. And Leo is working with me, especially with small children. And he has this special stethoscope. With this, he can listen to the thoughts and to the heart of children, and maybe asking children. So, what do you say? No, they are nice people. You don't need to be afraid of them. Yes. Okay. He would like to listen to your ideas. So, okay. Okay, he's wondering what happens. Yeah, okay. So he's very kind and listen to children and able to speak with children as well. So we will see a little bit later how it's happening. So just a small introduction about myself. Actually, I have been working with cancer patients for about 22 years in Turku University Hospital. I was with a psychiatric clinic, child psychiatric clinic, but working mainly for families. And I met about 80 families each year, and about 25 families where a father or a mother was dying. And after the death of the parent, I continued with the family for almost 1 year more psychotherapy. And the smallest children I have been working with were baby-to-be, because during pregnancy you may have cancer. And the oldest children were young adults. So maybe I saw 600 families with a dying patient. Usually it had been so that the oncologist in charge make a referral, is asking as a patient if it's okay to speak with Florence, who is psychotherapist. And we have to, of course, wait that the patient is accepting the consultation. And the time frame is usually 3 months, 1 year. We don't know how long this palliative care and terminal care is going on. It's often a proposition. It's not, and that the main difficulty is to be present without intrusive, and to often the patient have no specific demands. They are anxious, angry, deeply suffering of being abandoned, because many patients are understanding palliative care like the end of the treatment, and they feel abandoned. So we have to work with those feelings. Usually I start with interviewing first the patient and listening to his story as a story of the illness, because the patient have been through different phases of treatment and being in consultation, in oncology, in chemotherapy, radiotherapy, surgery, and all these treatment are very fragmented. And then is a need for coherence, a need for telling the story. Therefore, it's important to listen first to the story of the illness and about the structure and the history of the family. We have to check about 3 generations perspective, because we have often a story of cancer or disease over generations and how people have been dealing with those suffering and pain. And also to see that often illness is not the lonely problem of this family. You may have poverty, migration, divorce, separation. You may have isolation and a lot of other problems. And of course, to check about resilience and about resources of these families. And because we have so many different families today, about 20% families are single-parent families in Finland. So you can think about what does it mean if you are a single parent and you have cancer and you are going to die and you have small children. What are you doing? How you are coping with the situation? Then we have a lot of new kinds of setting. We have several children who are living in 2 or 3 families at the same time, because parents are divorced and making new families. And so the child is going from one family to another family, and somehow at the same time or after one, which is very complicated, because as a clinician you don't know which families you should address, which family you should work with, because maybe you need to work with several families at the same time. And what is happening in the family right now before this disease and before the palliative care? So we have maybe a baby has been born, maybe people are building a house, maybe you get unemployment, maybe you have elderly parents who have Alzheimer, and you have an adolescent at the same time, and then you have a very tired couple relationship. So it's not so easy to check what will be the focus of the intervention. That what the representation, the common representation of families we have. And this common representation of family is, of course, okay, but the problem is that it's very normative, and all what is different is not normal, which is very complicated. We have to deal with very different kinds of settings in families. I am speaking about a paradigm of simultaneity and complexity, because when you are working with families in palliative care and with people who are going to die, you need at the same time to deal with a very complicated set of situation, and at the same time you have to need many theories to understand the phenomena you are dealing with. And you have also to accept that the dialogue with the family is also moving yourself and changing something in yourself. So you need a lot of knowledge about medicine, because you need about, we spoke during lunch about this new medicine for sedation, and you need to understand what is that about. You need to know something about developmental psychology. What are the normal needs of children? 8 months child is quite different from a 3 years old child, and 5 years old child, and 20 years old child. And you need to need something about interaction between systems, about families and the holding and caring system. And then you have to need about you need to know something about what is happening on an intrapsychic level in the mental health, or the mental thinking of the patient. And of course of culture, because we have more and more people who are coming from different cultures in Finland too. So how does proximity of death affect people? I say often that people are walking on 2 feet. 1 foot is waiting for a miracle, that something will happen at the last moment and you will be saved and we will survive. And the other foot, no, I'm going to die, nothing has been done. But at the same time, people are walking all the time. So 1 foot and the other foot. And walking means to be not very in balance. You have to challenge the balance. So it's quite normal that people have, at the same time, a strong knowledge of what is happening and a strong hope of a miracle who will save them from, and that is nothing to do with denial. That is a reality which we have to, and people are walking, and so it's quite. And very often you will find some unfinished business with relationship, and especially in 3 generations perspective. Hate, anger, difficulties of relationships with parents, with grandmothers, with siblings. That's okay. But all this unfinished business is highly activated, so you have to address this. Then you have all those previous experiences of losses and previous experiences of divorce, and the traumatic experiences from early childhood and early interaction. We all have experiences of being taken care for during the pre-verbal time. So we know something, our skin, our memory skin knows something about being cared for. And this is highly activated when all the nurses know those people who don't want to be touched, who are afraid of all kind of caring. So all this is, and maternal preoccupation, which means that most of the parents are very feeling of shame and guilt for giving some pain to their children because they are going to die. And this maternal preoccupation is one of the most important thing you have to make alliance with to help people to go further. A lot of all kind of feelings, but especially the communication between couple is very often conflictual, and people are very often fighting together, and because they have kind of illusion, if they are fighting, if the relationship is complicated, it will be easier to bear the loss. Therefore, I have this one, which is a disease. And often I say to patients and their husband and wife, you know, the disease, the cancer, is stealing you ability to communicate. It's not your fault. He's stealing it. So what are we doing together in order to put him away from terrorizing you and making you unhappy? And this way is important because people have a lot of guilt about their fight. Even they know that it's not. So if you are accusing this one, it's helpful for the patient because it's not their fault. It's him or what the children knows. Actually, children need a lot of time to understand what is death. Actually, I think adults too have the same difficulties as children. It's nothing special for children. I guess that everybody has these old difficulties to understand what does it mean. The understanding of death is very slow, not only for children. And it's a huge tendency to think that we have to protect the children from knowing about the dying of the parents. Actually, the children knows. And when Leo is asking the children what they are thinking, we can ask him, if you think that you are 5 years old, Oscar, and Leo is asking you, what do you think now about the situation? And Oscar is listening to your thoughts. And then I ask Leo, are you sure I dare to ask this question? Okay, you believe that Oscar is thinking this. Okay. So Leo thinks, Oscar, that you are concerned about your mom, if she's going to die. So, and then you bring the situation. And often children are very, very like relieved to get to speak about what they have thinking so many times. So what I'm often speaking about, we have in common an external world. We are sitting together in the same room right now. This external world is common to all of us, but each of us has an internal world. Each of us has his own feelings, thinking, experiences, ideas, movies. Everything is and strictly personal. When people are in love, they are thinking that we have a kind of Bluetooth between minds, and then they have to learn that it's not working this way. We have to speak. So the parents actually are like decorating this inner world of the child, putting experiences of being with, experiences of being loved, of being comforted, of being understood. If this inner world is well built and is something inside, even in the outside world is happening very sad things, the child will survive, okay? So we have a lot of children whose inner world is not very well working. It's full of fear, of traumatic experiences, and so on. So, of course, when such a child is confronted to death, it's destroying him. So what is this inner world has been, we have to speak about that with children, what kind of inner world he has and how we are building it. We spoke this morning about denial, how to deal with those people who don't want to speak to children. So I think we have to be very, very respectful. I have been working a lot in Estonia and in Bucharest, in Romania. And in those countries, it was a question of survival to keep secrets and not to tell children anything about our personal life, because you were always afraid of, if the child is telling somebody, you are going to Siberia or you are going to camp and you are, okay? So in many families, even after 3-4 generations, you have a policy of secret, because it has been a question of survival. So you cannot break this survival system just no because you think it's important, but you can listen to it. You can ask children, you can ask people to tell me what would happen to your child if he would know what is really happening. What do you think will happen to the trust between you and your child when he will discover that you have been lying to him? Or what do you think the lack of trust will affect your relationship and the relationship of your children with your other parents or with your relatives? So you can just ask questions and being there. And what about trust in others? Because the child is building a representation of adults through the parents. You get the idea? So in Finnish, we have 2 words, toive and toivo, and we have the wish and the hope. The wish is that reality could be changed and everything will be okay. This is only a nightmare, and tomorrow I will be aware and everything will be okay. And we spoke about meaning and meaningfulness. Hope is the ability, growing in giving new or seeking for meaningfulness in your life and finding new meanings of what is happening to you. And what could be the new meaning? So, you remember this idea? Anxiety is quite normal. Usually in the hospitals, they ask a psychiatrist consultation for anxious patient, and they are sending the youngest student to the patient who is very afraid of, and giving benzodiazepine for 50 milligrams 3 times a day. Anxiety is something normal and is something you can work with, but you have to be the container of anxiety. And the first step, we spoke about compassion, is the first step is to take off this anxiety, to be a container for it. And the second step, to change the paradigm, which is from disease, from curing to caring, and from a disease approach to a parenthood approach. Because everybody wants to be a good parent for his child. The main trap nowadays is the formation of nurses and doctors is this idea of solution-focused training and problem solving. I don't know if in Sweden it's the same problem, that we have this problem solving, solution-focused approaches, which are, in my way, very, very, very complicated, because if a patient is going to die, it's not a problem to be solved. It's it's a mystery. And we know that mystery is not a secret. It's something which is not understandable with cognitive intelligence or sciences. Is something you have to stay in front of and to take in your heart and to be for that. So what I propose is a child-centered intervention with the emphasis for parenthood, and parenting is activated. Why? Because actually parenthood and parenting is a kind of rebellion against death. It's the way people are dealing with dying. It's having children. And then you have to try to enhance the competence of the dying patient, because one parent is competent until his death. Yes. What do you want to live and live for your children? What are you ready to do for your child in order that he will survive your death? This is a cruel question, but actually it's telling the patient that you are competent to do something for your child, even you are so in a weak condition. And just speaking about life, speaking about what is happening, speaking about families, and I use these toys usually, those monsters, and there you have the nurses and the doctors helping the family against this big beast. And then you have Leo, who is speaking with the children. And you have a kind of carpe diem psychotherapy, which is more or less creating a common narrative with all the family members of what is happening, and fighting against dissociation, because dissociation is one defense against fear and anxiety, and to be the container of suffering. So, of course, you have to be quite flexible, working with the patient alone, working with a couple, working with the children, working with the family, working with the friends, working with the staff, because often the staff is more anxious than the patient, and in general hospitals. Okay, that I can go over, but I will let you read this story of Patrick. It's a story of maternal preoccupation in a male patient. You will see how it's who is a good English speaker. You are a good English speaker. So you could read the story, so it's easier.
Patrick was a 32-year-old truck driver when he was diagnosed with a very aggressive cancer. He was told that there was no hope. His wife, Janet, was 28, and they had 2 boys, 3-year-old John and 14-month-old Tony. I saw them during the shock period, shortly after being given the diagnosis. Then Janet sent me an email asking me to speak with her husband because I don't know what he's thinking and it's driving me crazy. The next day I saw the entire family and I said to Patrick, no, sorry. That's right, huh? I went to the ward where Patrick was given some palliative chemotherapy to alleviate the pain. I found him sitting in front of the computer in the living room and surfing the internet. He was looking at tractors, and I sat near him, watching Massey Ferguson, Valtras, John Deere's, and New Holland tractors and commenting on them. Suddenly he asked me if I knew German because my name was a German one. I told him that I was French, but that I knew German. He asked me if I could help him to buy a car in Germany through the internet because a new law in Finland allowed the buying of cars from abroad at lower taxes.
So that you can see the demand of the patient. You never know what is really demanding. and how to listen to this demand and listen to what Because he may ask for something very different. So.
Okay. And the next day we started to look for a car. I saw that he was interested in a robust big cars with all the safety equipment like airbags, etc. While I was translating the technical characteristics of these cars for him, I said, "You want to buy a big, safe car. Yes, with Janet and the kids, you need a safe car. You want a maximum of security for them. No need to lie. I know I'll peg out. Janet has to keep on with the kids. Does she know that they are so much in your heart, that you are thinking how they will cope without you? Don't know. We don't speak so much. I'm nervous. I often yell. Shit's scaring cancer."
So you can see that's a maternal preoccupation of a male patient. He's preoccupied how his wife will survive with the kids and how he can do something for them. That's because he's not able to tell directly to his wife what is happening. They are fighting all the time. Most of the time we had to speak about their fights.
The next day I saw the entire family and I said to Patrick, "Did you talk about what you were thinking? You should tell her. You know better how to speak to her about what I'm thinking. Do you know, Janet, what Patrick is carrying in his heart?" Janet said, "As I know him, he worries about us, but we will be fine." I said, "Each of you wants to protect the other, but in fact, it's damaging your relationship. That is not what you want. Certainly not." Then John came closer and climbed into his father's arms while Tony went to his mother. I continued, "I've seen this before during cancer. It's a terrorist, just terrifying everybody, paralyzing the words in the throat, and then nobody dares to say the important things and how much we love each other." Then John took his father's face in both hands and said, "I love you so much." In October, we organized the transport of the car from Germany to Finland. In March, Patrick was in a bad condition. I saw him in the hospital. He shook terribly. He felt cold. I went to the store to get a blanket. I said, "You're freezing," and I took his hand in mine. "I was 15 when my father died," he said after a period of strange silence. I was holding his hand in mine. The silence was between us, joined only by the hum of the perfusion machine. "You stood alone in front of your father's grave."
So, and in this case, you can see the previous losses and unfinished business with family of origin. And because I have been a nurse, I know how also making this nursing stuff, which is very helpful. It's easier for a nurse to be a psychotherapist than a psychologist because they don't know about bodies and physical stuff.
Is there much left? We have to kind of, all right, let's see. The silence in the room was suddenly warmer. I added, "It was winter." "Yes, in January." "How do you know that?" "The cold you felt when you were 15 still makes you shiver." The impertinent March sun overflowed into the room. Patrick was no longer trembling. His hand was strong when he said, "I would have wanted to save my children from this pain." We spoke about dying too early, being alone, and Patrick mourned the fact of having nothing concrete from his father, nothing as a memento. His mother had thrown everything away. He imagined how the children would be as young adults. He wanted to buy some jeans jackets with a picture of Bob the Builder on the back, but Janet was against because they were expensive and not so practical. They had a fight about this. Patrick imagined that the jeans jackets would be like a second skin to protect the kids from feeling too sad. They would be a kind of sorrow jacket, a memory of his love and concern for them. When they felt alone or cold, then they would put on the sorrow jackets. We had to stop. Philip was tired, and the session took 20 minutes. Suddenly, Janet entered the room with a huge bag. She brought the jeans jackets. Patrick died 2 weeks later. We'll have to stop here.
Yeah.
Okay, thank you.
We have so short, yeah.
Very, very moving, very, very fine presentation. Thank you. Are there any questions for Florence here? Anybody? I can kick it off and ask you about this family-centered intervention. Are you one of many? Are there? Is it common to work the way that you work, or is this somewhat of a pioneer thing?
No, it's quite seldom, especially in Finland, where many people are very individualist, and there are not so many colleagues who are able to work also with very small children, because you need to have a non-verbal approach also with working to children. But that's the way I've been working, because I have been trained as a family therapist first, and then individual psychotherapist, psychoanalytic frame, and then as an early interaction psychotherapist, which is working with under 3 years old children and their parents, where the non-verbal communication is very important. So it's not so common.
Is it possible that you could have a supervision program, or you'd be able to work like this as a nurse, for example, if you had some specialized training?
Some things they can learn, but on a certain level you need quite a lot of knowledge, and also how to integrate the different aspects. That in the story of Patrick, you can see several features of what I told about: unfinished business, conflict in the relationship, 3 generations problems, maternal preoccupation. Maternal preoccupation also in male patients. We women, we are stupid. We don't think so much about male, which are parents. So, and then it's quite difficult to integrate all these different aspects, and you need a quite high experience in working with families. But you can teach nurses something about if the patient is cold, and having some, you might ask a little bit more, like you told about asking the wish of dying, about denial. Just be curious about what's the phenomenon. Yeah, just be curious and interested in what the people are thinking about.
Sure. Any more questions? We have someone here.
I'm interested in your thoughts about palliative care's teamwork. And often when it comes to symptom management, you have to think into different dimensions, the somatic, but as well the psychological. What are your thoughts about what's important to share with the other members in the team? And do you try to prep the patients to give his thoughts to the other members in the team, or do you share it?
Yes, the framework was a university hospital, and it was not a palliative care hospital. It was or a palliative care unit. It was a typical university hospital where we had always to fight with many doctors that don't do the decision too late, because they are keeping around. So, but it's important to have to participate to nurse meetings once a week at least, to speak with doctors, to speak with nurses, and to, if it's in a palliative care unit, yes, to share with all the people what can be shared, of course, because you cannot share everything which is told to you. And especially to support the nurses, because some of them are very, very anxious, especially when they have themselves very small children.
Thanks. And we have one more question here. Yes, please. Last question.
So just precisely on that topic of anxiety in hospital stuff, do you have any tips about sometimes you become emotionally involved with cases, especially, I mean, I guess I can imagine this case, obviously it would be very hard for anyone, doctors, nurses, whoever it is, especially when the patient passes away, etc. So at the end of the day, that person is not your relative, but you are a human being after all, and then you sort of relate to that person and to that suffering. Yeah.
That is, of course, a big question, how to deal with, because you are the container of so much pain and so much suffering. So you need to take care for yourself and for your mental state and the way to deal with anxiety. And yes, that's a very important question. And I think that everybody who is working with dying patients has to first to face and to think about own death. So I had the chance myself to be confronted with it because I went through surgery for a brain tumor when I was 37, and the surgeon said to me, there are 3 possibilities. One, you are dying on the table, but you don't know about it. Second, you are okay, but you will be maybe paralyzed or having a stroke, you cannot speak, or in 2 months you will be working again. So, and then he left, which is typical to brain surgeons. And I understood why brain surgeons are not looking at all at the patient before surgery. Because if the patient is getting a person for him, it will disturbing his competence and his work. So then I had to think about, okay, and once you have been through your own thinking about your own death, so you can, how you say it,
You have prepared.
Yeah, and dealing with it.
Yeah.
And also anxiety, once again, it's not a problem to be solved.
Thank you.
It's not something you have to solution-focused work to do. It's not a problem you have to be solved. It's something you have to carry in your body, in your mind, in your heart.
Thank you very much. Thank you, Florence. Thank you. And yeah, we'll get your sign. There you go. Vänta, var är hans skylt här? Är han? And we have our last speaker today before the panel, and it's Professor Christoph Ostgathe from Germany. He's a former president of the European Association for Palliative Care, the EAPC. He is professor in palliative medicine at the University Hospital of Erlangen. Welcome.
Thank you very much. At first, I want to borrow Leo, please, because I'm a little bit anxious. In regard to time, you guys are very strict, so I hope I will make it. I got it until 41, is that right? Yeah. Okay. And the second course I needed because the issue is not easy that I will talk about now, and I hope for a very fruitful discussion. Benedicta gave me 2 tasks, to talk about the international perspective on palliative care and the development in countries that legalized euthanasia. And here you see an outline of this presentation. I will talk a little bit about context. I look in the situation of palliative care mainly in Europe. I will look in medical assistance in dying, which is the internationally more or less now used term. I will look at the model pupil of euthanasia and assisted suicide, which is Canada. And at the end, there will be hopefully some time for discussion. I have a lot of conflicts, but no conflicts of interest. And all patients that are depicted here gave informed consent to be part of presentations. The first thought I want to share with you is when we think about end of life and palliative care, that we all have a picture in our minds. But end of life care has always been too contextualized. The way people suffer may be different, e.g. in different geographical regions, cultures, legislations, or economic backgrounds. And the way we look today at that, at the international developments, is also colored by our Western European cultural heritage and our history. If we look, and this is the shorter part of the presentation on the international perspectives on palliative care, the first context is, what are the palliative care priorities? In our nations, in our countries, starting up from the UK in the 70s, you already heard about Cicely Saunders, the main focus, the main priority in the beginning was cancer. And Cicely Saunders said, when she was asked, why didn't you look at all the other patients? She said, that role, that task was much too big. We started up with cancer. But nowadays, we are looking in palliative care in a much broader sense in our countries, all the way now into all patients that are older, nursing homes, dementia. But this is our Western perspective. In other countries of the world, for example, countries that we call low and middle income countries, these diseases are less present because there's a different social structure in those countries. And for example, communicable diseases, HIV and AIDS, resistant tuberculosis, other infectious diseases, these are the priorities of palliative care. Another context is the development in the different countries. This is a study done by the IHPC and WHPCA on the levels of palliative care provision in the different countries worldwide. The greener the color is, the better is the development. And in the red countries, there is rather less development of palliative care. And as you imagine how much suffering is in, for example, the sub-Saharan region in Africa, you see that their palliative care is far underdeveloped. Another context is the availability of medication. We have heard a lot about physical suffering as well today, pain, dyspnea. The question is, how well is, for example, opioids available in certain countries? The Lancet has worked intensively on that issue in the last decades, and you see here a very weird map of the world, and you would say this doesn't look like a world map, but the size of the country relates to the amount of opioids that is available in this country. You see this big fat countries here, Canada, USA, and Australia. This is Africa. It's gone. There's almost no opioid to treat patients who are in need in these countries. And this inequivalent distribution, we have about 300 metric tons of morphine equivalent opioids distributed in the world each year, 300 tons. Only 0.1 ton goes to the low-income countries. 0.1 ton. This is almost nothing. This is an important context. Looking here closer into the situation in Europe, one basic number I want to share with you is how many patients die every year in Europe. And you see here a map, and the darker the map is, you have more patients dying in these countries, and you can see that in Eastern Europe, more patients per 1,000 patients die per year, and overall, and this is an important number you should memorize, about 7.5 million Europeans die per year. And it's an honor for me to share some data of you. You probably have imagined that already. You see this young man, you recognize him. He won in 2019 the EAPC prize for his work that he's been doing of mapping the situation of palliative care in Europe. It's really a very interesting resource You can download that from the app. You can follow the QR code, or you just give in Google EAPC, Atlas of Palliative Care in Europe. And this is really interesting also to see how the situation is in your country. And when you remember that I said that the number of patients dying in Eastern Europe, and here you see specialized palliative care services for adults, the bigger the bubble is, the more services there are in that certain country. That in the countries in Eastern Europe, where the rate of patients dying per 1,000 and that the need for palliative care is higher, the availability of palliative care services is lower than in other countries in Europe. So we also see here a very imbalanced distribution. Here's the table. You see that for a German, it's hard to see that Austria is on the first place, having the most services per 100,000 inhabitants. Sweden is not doing too bad. So it's I would say if you see all the countries here, it's already Champions League. And the European Association for Palliative Care recommends 2 special palliative care services per 100,000 inhabitants, 1 home care service and 1 hospital team. So you see there's still a long way to go that most countries don't meet that threshold. I think one of the most important issues, and we heard about that already today, is education. Just let me give you one insight on education, the training of physicians. That palliative care and what we think is really essential is only very little as mandatory training in under and postgraduates. And you see here that, for example, the possibility to be specialized in palliative care is only available in a very few countries. UK as the motherland of palliative care, Ireland, Poland, and Slovakia, and Sweden. Did it change? Because it's a subspecialty. Full specialization you have in Sweden? Subspecialty. There you go. There you go. Whew. You did okay. No, that's okay. That's okay. So, concluding, we have a dynamic development in many countries in Europe over the last 50 years. It's a story of success for a new field, but only in some countries. In many countries, it isn't. Many countries have integrated palliative care into national laws, but the provision, as I said, is very heterogeneous. And this is something that really hurts, that provision follows wealth. Palliative care follows there where the money is. There where the resources are low, also palliative care is less developed. And in some countries, there's hardly no palliative care development. Okay. So we have to bear this in mind, that we have regions in the world where palliative care is really very much underdeveloped. In a parallel, we are looking at the developments regarding legalization of euthanasia. And just like Carlos, I want to share a very brief story with you. A patient we've been treating on the palliative care unit maybe 3 or 4 years ago. And a young woman, she was suffering from a breast cancer. She was suffering from dyspnea. She had two children, and both were, young adults around 20 years old. And she was really suffering intensively. And she wanted to go to Switzerland to receive assisted dying, but she was too weak to go. And that was the situation. Palliative care came into action, and she was transferred to the palliative care unit. And what we did, we made a contract. She really had a very strong desire to die. Really, she wanted us to do something. She asked for the pill. She asked for an injection. And what we said, give us a little bit of time, a few weeks. We want to look at your symptoms. We want to, talk to you, talk to your daughter, your son, and I promise you, we promise you, in case you will suffer unbearable, we will intentionally sedate you in this case. And she said, this is okay. Let's go and try it. I will finish that story at the end. Many countries have thought about how to cope with patients at the end of life. What is our core aim? And palliative care has evolved, but at the same time, also what we would call medical assistance in dying has evolved over many countries worldwide. We look at three different aspects. One is physician or non-physician assisted suicide, which is legalized. That would be in blue, legalized by court ruling, but not legislated or regulated, so it's depenalized, so you won't get a panel on that. And you see that in some countries, yes, you have Canada, Australia, some countries in the US, also in Germany, we have the situation that it's not penalized by court ruling, and we just heard also about the situation in Spain. But in many countries, it is illegal or we don't have the respective information. And the second possibility, one is assisted dying, so the patient takes the medication himself, or euthanasia, and there is the doctor applies the drug. Or a second version is, you forego treatment to allow natural dying. There's also regulation on that worldwide. We have some countries where active voluntary euthanasia is legal. This is Belgium, Canada, Colombia, Luxembourg, Netherlands, New Zealand, Portugal, Spain, Australian states, and New South Wales, Queensland, South Australia, Tasmania, Victoria, and Western Australia. That passive euthanasia is this foregoing treating to no natural dying is legal. Active euthanasia is illegal is white, the white countries, and all forms are illegal are in red. So even foregoing treatment to allow natural dying is not allowed. But you can see it is a global issue. It's not only the Benelux countries anymore, it's a global issue. And I said it already in the beginning, the model pupil of medical aid or medical assistance in dying is Canada, and I want to illustrate the development and looking at the case of Canada and the evolution of MAID over the last years. It started much early, but this is the first evidence I found that it was discussed in a special committee of the government to talk about ethical issues related to euthanasia and assisted suicide. By this time, all these measures were illegal in Canada. In 2015, Quebec is, within this model pupil group, Quebec is the fastest evolving country. Before other provinces in Canada, they allowed that a physician may assist a patient under circumstances when he is unbearably suffering with an incurable terminal illness. The doctor may assist the patient in dying by euthanasia or by assisted suicide. And the other provinces followed in 2016. They had strict eligibility criteria. For example, and this is important, a reasonably foreseeable death. So there's a patient who will die soon that can have the possibility to receive medical assistance in dying, plus, and this is important as well, a 10-day reflection period. So there's a time period between the wish, the asking for it, and the performance and doing it. That was changed in 2011, and I think this is a major milestone in the development. They took out that criteria that death has to be reasonably foreseeable. So euthanasia and assisted dying could be also done in patients with other diseases. We all have pictures of cancer in our minds. And here you can see the typical diseases. Many of the patients have cancer. It's diseases of the heart, other conditions, respiratory, neurological, multiple conditions, organ failure. And if you take a closer look at the other conditions, you see patients suffering from osteoarthritis, osteoporosis, fractures, vision hearing loss, so being less able to see and hear, dysphagia, frequent falls, and some others that you wouldn't expect there. Then, in 2021, same year, the requirement for a minimum of 10-day reflection is removed for those whose death is reasonably foreseeable. If they have another disease, it's 90 days between the first wish and the time where you can perform euthanasia. But for a foreseeable dying, this 10-day period is removed, so you can have your wish and it is performed more or less right away. And keeping this in mind, also as Carlos said, that the wish to die is volatile, is changeable. It could be very intensive in the morning. It could be completely different in the evening, and that in the same patient. And plus, we have patients that have a wish to die and a wish to live in the same moment. And one evidence for this volatility is a study that has been made in Ireland, and there was not cancer patient, that was an aging population in different waves, and they were asked whether they have a wish to die. And you see that some people were lost in follow-up. Some said there was a persisting wish to die. The majority said no, there was no reported wish to die. And this changed over the time, back and forth. So it's not a wish to die is a wish to die, and it's stable like this over the whole time. In 2022, it was made clear that you can always also put it in a kind of advanced care planning. You can say, I will, in case I get dementia, euthanasia can be performed even if in this situation every sign of my natural will is completely different. And we have situations like that. In 2023, palliative care homes and hospices may not exclude medical assistance in dying from the care they offer, which means, for example, that some hospices do not receive money anymore. This hospices is to lose funding because they ban medical assistance in dying in their institution. Probably in 2024, it is already law, but the government has put a waiting time. It was in spring 2023, now it's postponed to 2024. That MAID is already also possible for people with mental disorders as the sole underlying condition. And I read a paper on that issue, and if you look at suicidal prevention, it is clear that people with mental illness are overrepresented due to the disease among the population of people who die by suicide. And it's completely unclear how this permitting assisted suicide for people with mental illness might not be seen to be undermining efforts to reduce suicide rates in many countries. And what will come in the next years to come can be questioned. To get an insight about the numbers, I said Canada is really the model pupil of assisted dying worldwide, started in 2015, and by now they overran with their numbers all other countries in the world. I think here you see the total numbers from 2016 to 2022. It's 44,000, and this leading per capita in the province of Quebec. And you can see here the death rates in the different provinces. Here are the different provinces in the countries. And then the percent of patients that died under the MAID Act has risen in every of the provinces, and mostly in Quebec. And in that state, already 6.6% of the patients die through medical assistance in dying. So if we remember, 7.4 million Europeans die per year. If we take this 6.6% as a basis, this would be around 500,000 deaths in Europe through medical assistance in dying. At the end, just to make it sure and collect a little bit, and also for our discussions, what are possible risks of regulations regarding medical assistance in dying? If we are rather on the restrictive model, or as Canada on the permissive model. If we have the restrictive model forbidding euthanasia and physician-assisted dying, we will surely disregard individual full autonomy. And some people will suffer. This is completely clear. We have to be clear about this. Autonomy is something really growing as an aspect in the world, so we will have people suffering. On the other hand, if we have a permissive model, it's clear that we have pressure on vulnerable populations. If you see the Canadian data, 1/3 do this because they perceive themselves as burden on families, friends, and caregivers. And this is data from Oregon, that the more people perceive themselves as burden, and this has risen over the time, the more they ask for here physician-assisted suicide. And if they're concerned about finances, the same thing has arisen over time. There are many more risks. I won't go into that in detail due to the time restriction, but what we always have in palliative care used as one of the main arguments was slippery slope, that with 1 year to the next, new groups want to enter this kind of possibility to end their time, end their life. And in the case of Canada, we can see that this argument is correct. But for me personally, I have full understanding if you have always said palliative care is not the answer to every suffering. Sometimes there are situations like that. But if we, for these few people, and it's really a very small number, build up an infrastructure, that puts then a lot of pressure on other populations. We have to be clear about that. So at the end, person-centered and compassionate care needs have to be prioritized with greater access and equitable access to primary and specialist palliative care globally, in our countries and globally. And we have to look at the mental health of person with incurable terminal illness, and we have to support the caregivers to allow patients to die naturally with optimized care. And at the very end, not at the very end, almost at the very, almost, just another 2 minutes. I want to remind you that our organization, the European Association for Palliative Care has written a white paper on that. We probably have to rework it now because things have changed over the last 8 years. That this paper is old now, or 7 years. And in this paper, the EAPC has stated that the EAPC respects individual choices, and I think this is important for euthanasia and physician-assisted suicides, but stresses the importance of refocusing attention onto the responsibility of all societies to provide care for their older, dying and vulnerable citizens. A major component in achieving this is the establishment of palliative care within the mainstream healthcare systems. If you look into many countries, we are far away from palliative care being the mainstay within the healthcare systems. For the EAPC, and I think this is also important, we have to develop an attitude, a clear vision. And this vision is that euthanasia and physician-assisted suicide is not part of palliative care. And it will be interesting what happens in those countries where they have both developments, palliative care. Spain will be very interesting over the next years. The answer to the question what national regulations mean may be different from service to service, from expert to expert, from professional to professional. However, we as palliative care people cannot bury our heads in the sand like an ostrich. We have to find a way of dealing with the situations in all these countries without betraying our palliative care principles. And I want to end with the end of that brief story. The patient was with us for 5 weeks. I can hear the assurance when I say 5 years. No, 5 weeks. And the daughter stayed with her the whole time on the ward. She had a bed, and they shared the room. And at the end, dyspnea really got bad, and she was, we would say she was beginning in the dying phase. So we did as promised and started intentional sedation for the last days of life. And one of the nurses was so smart to ask her, you remember when you came to the palliative care unit? The only thing you wanted was to die. And if we would have had a legislation like that, wish and then perform, she would have died, probably. And she said, I was so stupid. If I would have done that, I would have missed my best 5 weeks. That was the time I had with my daughter in those weeks of life. So thank you very much for your attention. I think the great philosophers of our time really declared that some days we will die, all die Snoopy, true, but on all the other days we will not. I want to invite you additionally to that, to the next EAPC conference, which will be held in wonderful Spain, in Barcelona, on the 16th to 18th May. And also this issue probably will be intensively discussed in the sessions and, most importantly, in the coffee breaks. Thank you very much.
Good job. Thank you very much. Thank you so much for your presentation. I would now like to open up for questions. Is there anyone who would like to ask a question? Here we have one.
Thank you for your presentation. I would like to ask if there's any research on how to determine when patients are or should go into palliative care, because my experience has been that that differs a lot. So I wonder if you could talk about that a bit.
This is a very good question, because this is a day-to-day clinical challenge to really recognize the right timing to integrate palliative care. From our hearts, I think you would support it fully, palliative care as early as possible, sometimes already with the diagnosis of the disease in parallel to the curative treatment, because some patients already have the needs. And we know very well that the earlier we integrate palliative care, we have the famous Tamil study with all the discussions we had around it, but the earlier we integrate it, we know that from systematic review, the better symptom control is. We do not know, as far as I know, how that has an impact on the wish to die on the long run, but I'm very sure that it may have a positive impact. We have strategies. There is, what we call screening. That's what we do every day in our cancer center for palliative care for cancer patients. So you can do self-assessment. There's studies on that. There's data on that. There's proxy assessments. And what is completely clear is that if you use a screening tool like that, four times higher is the number of patients that are detected with their palliative care needs. The major problem is that we have to cope with is the missing knowledge about palliative care in the public, in the patients, and in the professionals. Yeah. Just yesterday I had a patient that said to his doctor, I want to have palliative care. What his answer was, you are not that far yet. Forget about it. Yeah, there is a misconception about palliative care. And in 50 years now, we're doing palliative care. And this is an issue we haven't solved so far. So if you have a golden solution.
More questions? Anyone's? We have a panel discussion too. Here you go.
Thank you, Christoph. Very good, nice, interesting slides and presentation. On one of the slides, you have passive euthanasia. I thought that was sort of outdated. You don't talk about passive euthanasia. Could you comment on that?
Yeah, that's why I put it in the title, foregoing treatment. That's how we call it nowadays. Yeah. So yeah. But in Germany, for example, we are in the public debate. Yeah, we are as professionals, we use our terms and we know what we mean. But in the public debate, they're still using all the other old terms, and that makes also and I'm grateful for this remark, also a confusion. Yeah, because people ask for euthanasia and they think it's just foregoing treatment. That's what they're asking for, and then people on the other side think it's on killing somebody, which is in many cases the case. But this confusion doesn't help in the discussion.
I have a question. I don't know if I misunderstood, but it seemed to me that Canada has both a very fat country in regards to palliative care, yeah, and it's also the country where they have gone the farthest in the euthanasia program. Do you have any explanation why that is the case? I mean, what is it? What is driving the euthanasia agenda, if we call that, the way it's been gone?
That is, why does a country decide the way? It's in Europe. I would always say, for example, the Netherlands was at the forefront of developing euthanasia in their country, and it has always been a very liberal culture. So they smoke pot wherever they want, which, in Germany, we've been discussing this in the parliament for 15 years. And so that it's a little bit about the culture. Maybe this is, but not to confuse it, but the big USA and the big with the opioids, that may also have other... Yeah, but there's, it's just to show the disbalance. We have, for example, the opioid crisis, and many of the opioids that are distributed in the US and some in Canada are not for the regular palliative care patient. They're given, for toothache, and then we see all the problems in the aftermath of that. So, but what is clear, I've been following this discussion for 25 years now, and what was the concern in the beginning was in countries where we have euthanasia that palliative care may not evolve as good. But I don't see that. Spain is a really a good country for palliative care, and still there was a discussion, now there is a legislation regarding medical assistance in dying. I think there's no interrelationship. Not evidence-based, eminence-felt, yeah. But why that is in Canada, maybe it's also this Northern American liberal perspective, culture. Maybe anybody else has an idea why is that so. And they have very strong lobby groups, and you know, you start with a very ill, incurable cancer patients, and suddenly this lobby group, why is it only for them, and this is not fair, and so you have all these discussions. But there's also some negative discussions in the country as well. They see this pressure on vulnerability. And there are some few cases where it has been really discussed publicly, that people were pressed into. There's one, you can Google it. There's one famous young man with a neurological disease where he audio taped his talk to the social worker, and he wanted better care for home, and he offered assisted dying. So
it's like an illustration of the slippery slope in Canada. You know,
yeah.
It's like the one thing gets taken away, they take away the next thing.
And again, but I'm not morally, the wish to die and the wish to ask somebody else to help. For me, it's neutral. It's just if we build up an infrastructure, and that builds some pressure.
Okay, thank you very much. We have a panel discussion left, and we're going to have a little break now. We're going to have some coffee, and we would like you to talk among yourselves, discuss, and relax, and we'll see you at 3:15. Okay, thank you very much.